and I work as a consultant psychiatrist for adults with learning disabilities in Havering. And obviously, we are part of Northeast London Foundation Trust, which covers Waltham Forest, Barking and Dagenham, Havering, and Redbridge. So, and today, myself and Asha would be speaking a bit about reasonable adjustments. And what we thought we would cover in the next 45 minutes would be a bit about health inequalities in people with intellectual or learning disabilities. What are the 5 good communication standards? How could we support these individuals to access annual health checks successfully? What are the resources out there? And also, how do you access support from specialized services if you need them? So to start with, who are we talking about? So these are individuals, adults with a learning disability or intellectual disability. And nationally, there are approximately 225,000 adults who are known to services. And when I say known to services, there is a whole lot of population who are not known to learning disability services and who have been managed and are being managed within primary care settings. Also, there is an increasing number of adults with complex health needs, and that's partly due to the advances in medical sciences over the last few decades, where a lot of children with complex health needs would not have survived. Now they are surviving into adulthood, so we are coming up with them as well. So people with learning disability, as you might know, have higher mortality. So males and females die 20 to 23 years younger compared to general population from the latest letter data. They have higher rates of certain cancer, for example, gastrointestinal. The death rate is almost double in people with learning disability compared to general population. The trend follows with cardiovascular and respiratory diseases, and they also have higher prevalence of epilepsy. So 1/3 of my caseload have comorbid epilepsy and are on anti-epileptic medication. Also, they have a higher proportion of individuals with sensory impairments, or hearing or visual impairment. They are more likely to have dementia. So it's not just people with Down syndrome, whom we do know have a higher propensity to have Alzheimer's dementia. And it's usually the onset would be at a much younger age in the early 50s compared to general population, whom we are seeing an onset around in the 70s. But even without Down syndrome, people with learning disabilities are at high risk of developing dementia and a much younger age, so probably early 60s onwards. They are at higher risk of having mental illness. So schizophrenia is 3 times more common in people with learning disability compared to general population. They're much more likely to be given psychotropic medications, and it might not necessarily be to treat an acute mental illness. Very commonly, medications were prescribed in the past to manage behaviors as a form of chemical restraint as well. They are more likely to be obese, have a poor diet, and sedentary lifestyle. And these three on itself independently are a cocktail for poorer health outcomes, both physical as well as mental. Health needs can be associated with certain genetic conditions. So with Down syndrome, we do know that they have higher risk of having hearing impairment, cataract, congenital heart problems, blood disorders, GI problems, hypothyroidism, depression, and dementia. And access to healthcare is probably the reason why we all have gathered here this afternoon for the talk on reasonable adjustments, because from the information that we have, especially from the mortality reviews, we know there is disparity in accessing healthcare. They are much less likely to receive a health check from a general practitioner. They're much less likely to be offered screening or even take up the screening, even when they're offered, and also less likely to have an assessment of their sensory needs, especially when we know there are a higher proportion of them do have sensory impairment. They're less likely to receive health promotion advice, for example, smoking cessation, diet, exercising, alcohol consumption. They're more likely to be discharged early from hospital. And this is definitely a trend that we saw during COVID times. It was amplified many times, not just locally, but nationally as well. The people with LD were discharged much early from hospital, leading to poorer outcomes in those individuals. They're less likely to receive surgical intervention, so the understanding around the legislations which are there to help us out, so MCA, Mental Capacity Act, as well as deprivation of liberty safeguards, is not the best when it comes to its application in this population, and which might mean that they do not get the treatment that they need at that point of time. And a lot of undiagnosed and untreated health problems due to accessibility. And it all started with the MENCAP report, which came in 2007 called the Death by Indifference. So it's actually the stories of 6 people with a learning disability who unfortunately died whilst receiving or when they received NHS care. I don't know if anyone has read the document. It's quite hard hitting, quite difficult to go through 6 stories in one go, but I think for us, it's really relevant because one of the cases or one of the patients who's been mentioned in the document was actually a local patient. He was from BHR, was admitted to the acute hospital because he had a fracture of his femur. And unfortunately, during the surgical correction, he wasn't given his anti-epileptic medication. So that information was withheld. He went into a status whilst he was on the operating table. He was then discharged before he was actually medically fit. He went back twice to a hospital complaining of pain. Again, it was just symptomatic treatment. No one actually looked. And finally, he actually passed away, unfortunately, due to sepsis. And I think that case, especially because it was so local, it actually drives home the point why we are here today. What is the need to have annual health check and what are the adjustments we can make? As a result of that document, obviously, there was a series of national documents that came out where the healthcare for all, as well as the joint ombudsman report about 6 lives. And probably more relevant for us in today's world is LEDO, which is the mortality review for people with learning disabilities. And it's been going on since 2014, and annual reports are produced. And the positives of that, over the years, we have seen that the proportion of cases where we see good quality care has increased. However, the downside of it is the areas where we actually see a gap or where services need to be improved are the same. So there hasn't been much shift in those areas, and they are not rocket science areas. It's very simple. So lack of provision of reasonable adjustments, mental capacity assessments, coordination of care, recognizing deterioration in our patients, and again, coming more locally with the COVID times, one of the findings which we found in our reviews were patients were getting admitted to hospital, or their duration of stay within acute hospital was much shorter compared to general population. And that might be because staff supporting them or the team supporting them in the community were not picking up that early signs of deterioration and getting help when it could make a difference. And families and care homes not reaching out to specialist services. So, how can we, as medical professionals working within the teams, make a difference? I think attitude definitely goes a long way. So, people with LD have the same rights like anyone else. Knowledge about reasonable adjustments, and that's the reason why we are here today. Awareness around capacity, and also what are the enhanced services that we have. And on that note, I pass on to my colleague Asha, who will take us through reasonable adjustments.
Thanks, Biddy. Sorry, I just lost this. So reasonable adjustments come from the Equality Act, and there's a description there for those that it's about what can we do to make service more accessible for only people with learning disability, but with physical disabilities too. So on that note, if we go to the next slide, Benny.
Sorry, Ash, I'm trying for some reason.
Apparently my voice is breaking up. I have the greatest internet connection.
Yeah, so your voice is breaking up.
I'm going to try to stop my video and see if that helps.
Okay.
I'm going to stop sharing and
It was working so well. time comes to my part, and it's
Yeah, there we go.
right. So, and the point on reasonable adjustments, hopefully people can hear me, is that shouldn't, with learning disability aren't asking for big or expensive changes to be made. It's just simple things that can be done every day. And start off by establishing the 5 good communication standards. This comes from Royal College of Speech and Language Therapists, where, in order to communication and really find the voice of people supporting, what are the 5 services need to be doing. And my voice is still breaking up. This is great. Let me quickly try and change my internet. All right, I've switched my internet. Is it any better? I'll keep talking. Hopefully that can be heard.
A little bit better. It's still cracking up a little bit. Sorry.
No.
Bola, I'm just wondering if it's an issue with the internet connection. Maybe if Asha can dial in, and I know it's a bit hard to do it like that. We just have to sort of sync when she calls in and the slides, and then that way she can sort of view it on screen, the slide, and but the voice will be clearer on call. There is an option to dial in, isn't there?
Yes. Yes, there is an option to dial in, so I can do that. See if it works.
Yeah, see if that works.
Hello, this is Asha. Oh. Hello, can everyone hear me now?
Much better, yes.
Okay, there we go.
Perfect.
All right, so 5 good communication standards, of which I think number 6 needs to be having a good internet connection. So Ben, if you move to the next slide, we'll go through the 5 good standards. So the first one is having information available that tells people how best to communicate with the service user. And that's through using something like a communication passport or profile or guidelines that says, this is how the person communicates, this is how best to communicate with me. I have a high-tech communication device. I use Makaton signs, I use PECs. This is how information needs to be presented to me, and this is how I then process that information. yeah, and also this is an ongoing document that needs to be updated by those that work with the service user, that being carers or families or whoever is involved in that person's care is updating this document. So on to the next slide. Is it still a bad line?
I can hear you perfectly. The sound is fine. The
Okay.
sound is fine.
So yeah, again, it's not just one person that needs good internet connections. We all need that in this COVID times. So the second communication standard is staff being able to help and be involved in decision making. So again, using that communication profile and having staff that's available that knows how best to communicate with the service user and is there to support them with understanding information and making choices in order to then ensure that the supports that that person's receiving is what is right for them. So then the third communication standard is staff that are able to then support the person to make their choices and needs known. So it's a two-way street. Communication is a two-way street. So being the more competent communication partner, needing to know how best to communicate with the person, but also how to support them so that their choices are known and that they're involved in the decision-making process. And also, if they need support from a speech language therapist in order to develop those skills, we're happy to help. So the fourth one is having lots of chances to communicate and having staff that are available and make time and create those opportunities to communicate. It's not just we're doing communication therapy right now, it's throughout the day having opportunities to have choice and to be involved as much as possible. And then the last one is having staff there that can help the service user to understand and communicate their health needs. This information needs to be kept up to date and it's used amongst not just care home staff and families, but also with health staff, staff being able to recognize when that person's in pain or if they're feeling ill, and then to support them to access the right medical interventions and to communicate that across to whoever needs to know that information. And so then there's resources available here. I did have a YouTube video to watch, which currently, with my current internet issues, not sure if it will work, but basically it's a video about how do we make reasonable adjustments and it's from MenCap. And I can put all these resources into the chat afterwards so that people can access it on their own time. And yeah, it's just about what people with learning disabilities are wanting in terms of reasonable adjustments. So which I can talk about on our next slide.
Before we move on, is this the YouTube video, the MenCap one?
Yeah, it's the second bullet point.
Do you want me to try and play it?
We can try. See what happens.
I don't think it works.
That's all right.
Sorry.
Yeah, I think it demands a lot of their internet. So moving on to reasonable adjustments. So firstly, plan ahead. So make a plan for what reasonable adjustments need to be made. Things like maybe booking in double appointments, choosing the right or quiet time of day, thinking about access difficulties and looking at signs, noise, and environment, thinking about mobility and sensory needs. The reception staff have LD awareness training and looking at waiting room arrangements and how to prioritize people in the waiting room. And I'll talk about all this a bit more in detail. Looking at accessible invitation letters and if there's support required from the community learning disability team nurses. So So in terms of accessible letters, there's lots of those available online, and just in terms of when creating an accessible letter, thinking about putting pictures of the building, the waiting room, and of staff onto the invite letter, so it prepares the person for that appointment. They know what to expect, and it just makes it a bit more recognizable and a bit more real for them when they're going to, especially if they're going to a new practice. Come out and meet the person in the waiting room. The GP practice that I'm registered with, my name comes up on a board and it tells you which room to go to. And for some people with a learning disability, they might not understand what that process means. Offer people where and how they want to sit when in the appointment, as some people with learning disability may not feel particularly comfortable sitting directly opposite someone, and making the appointments when the surgery is less busy, so there's less chance for them having to sit around in the waiting area. And especially if there is long waiting times, offer, if there's a possibility, offer an alternative quieter waiting area, or talk to the person and their carer to talk about if they wanted to wait outside or go for a walk around the block whilst they're instead of waiting in the waiting room. So on to the next slide. If it's possible, offer appointments with a nurse or the GP of their choice, and offer extended appointments. Because for an annual health check, there's lots of things that need to be covered. So having that extra time and that extra time for that person to process information, extra time for carers to provide all that extra information, and maybe thinking about using a hybrid approach. So starting off the consultation through video or telephone, and then following up through face-to-face. And that extra time just helps understanding of information. So speak clearly without jargon, and work with the person's supporters. And this could be a support worker, carer, or family member, because they're the person that knows most about that person and can give you lots of that information. But also remember to try and include the person or the service user and support them to make decisions. And the supporters are there to help you communicate information to the service user. Use hospital passports, as there's lots of information in this, especially in terms of how that person communicates, their likes and their dislikes. There's lots of information available in easy read format, and that was one of the resources that I'll put into the chat. And ask the person or the support person, what do they need in terms of what, in regards to reasonable adjustments, what works for them. And I think that's it.
Brilliant. Thanks, Asha.
No worries. And I will put those resources into the chat.
Nothing that
Just to mention, sorry, Vinny,
right,
this slideshow will be shared with everyone that has attended. And I believe, correct me if I'm wrong, Bola, but it will be available, the recording will be available to view as well.
Yeah, it will be on our website by the close of play on Friday.
Thank you.
Thanks, Ms. Uma. I just wanted to say a couple of things. So one is obviously about making the reasonable adjustment, but it's also about sharing the information. One of the things which we don't do really well is actually share information between different agencies. And very often these clients, because of their multiple health needs, they will be open to their GP, they would be open to a mental health organization. At the same time, they would be receiving secondary care input from acute hospitals as well, at least one specialist, if not more. And it's about how do we share this information and make sure everyone who is involved in their care are aware of what's happening with their care rather than looking at them as bits and parts. And I think GPs are in this unique position where you actually are able to see the person as a whole rather than different parts of mental health. Okay, your liver, your kidney, your epilepsy, so on and so forth. Uh, so one of the things which we are driving is the use of CHC, which is available, CMC, Coordinate My Care, sorry, which is available for GPs to use. So once you complete your annual health check and have the health action plan, you can upload the document onto Coordinate My Care. And the good thing of CMC is it is there for view for acute staff, as well as for ambulance staff, as well as for mental health staff. And it's the same for us to make sure the hospital passports and communication passports, when we do complete them, we upload them to CMC so that the GPs can access it and we don't have to keep asking for these information or information not being passed at all. So that's one area where we can definitely improve our practice on. And also the second thing which Asha is quite actively involved in is using apps like the My Health Guide app in actually empowering our patients to take control of their life and their health. So it's something which again can be used in preparing them to have the annual health check, knowing a bit more so they can send you the information about their communication needs, about their sensory needs, so that you can adapt the clinic setting according to their needs and make it a much more successful annual health check rather than one where we are having difficulty. So yeah, there are things out there which is happening, which please do use, especially the Coordinate My Care and any apps which the service user might have to help the communication between parties.
Yeah, on the My Health Guide, one of the things that we're doing is sending push notifications to service users to then fit in what reasonable adjustments they need. So do they need easy read letters? Do they need longer appointment times, so that you have all this information readily available to then, when booking in that appointment, you then know how to do it.
Do you have any questions?
There is a question which someone asked, and I'm just going to read that out. Bear with me. It says, how do we deal with the very low take-up of health checks due to COVID-19? That is one of the questions that was posed.
I think whilst we are raising awareness about these needs within the GP settings, we're equally raising awareness within our client setting as well, saying that you are eligible, annual health checks are still going on, do access, do contact your GP. If you're offered, do take it up. What I would recommend is if there are particular clients who never turn up for health checks or are refusing and it's quite difficult for you to engage, do feel free to contact the local learning disabilities team. And if they are working with them, they would be more than happy to facilitate that discussion and actually to bring the person. So we had a client in Havering who actually never attended the annual health check, and GPs have struggled over the years to actually engage the individual. He was referred to our service, and our health facilitator and community LD nurse actually did an intensive piece of work with the client and his partner, who is quite anti-medicine. And the GP actually did a home visit, and the annual health check was complete. And as part of that, we picked up that he had early stage prostate cancer. So that was a good outcome that it was a timely intervention, but do request that support from the LD teams, because that's what we are there for if you are struggling with engaging the individual in attending the health checks.
Okay, thank you. I've got Mark who's raised his hands. Mark, I don't know if you'd like to add anything to that.
Yes, please. Just to let you know that we had a fantastic response this year in our completion of LD health checks. In Havering, we had 80% completion. In B and D, we had 88%, and also in Redbridge, we had 88%. And we've also raised the prevalence, so we've identified a lot more patients. I think there's about 300 more patients with LD. So it's a great achievement. So the checks, it was actually better than pre-pandemic levels. So the performance was better than 1920. So just well done to everyone.
Okay, thank you, Mark. The other question that I have here is, what should be included in a good plan, in a good care plan for learning disability patients?
If we're looking at the health action plan, it depends on the need, but what would be really helpful is being quite specific about what the action is, who would be doing the action, when it will be reviewed. So if we have these three key elements included in that plan, that would make it quite a smart plan, and that would be easier for people to follow up as well.
Okay, I think those are the only questions that I can see that people pose when they register for the program. But if you do have any questions for Dr. Binin and Asha, please put it in the chat box so we can have a look at that as well.
I think if there are no questions, Paula, shall we draw it to a close?
That's fine. I can't see any question coming in. I would like to use this opportunity to say thank you both to Dr. Bini and to Hasa for taking time out to present and provide us with this useful information. So that it was really useful to hear what is being done to support people with learning disability as well. So, but if people have any questions they would like to ask, you can send me an email and I will send that question across to Asha and to Dr. Bini as well. I'm assuming, I don't know if you would like to add anything to the webinar.
I just want to say thank you, Bola, and to the Training Hub for facilitating this and for your support. And I will also provide our team inbox just in the chat. So in case there's any other questions, people can email nel.lda@nhs.net. And just a reminder that there is another webinar on the 27th of May, which is End of Life and DNA CPR, which will be led by Dr. Jyoti Sood. So if you haven't registered your interest already, please do so. The links and the dates are all on the flyer that was shared. If there are no questions, I think we can close it here. And hopefully.
Hello. Hello. Yeah. I didn't register for the call.
Okay. I think it was just someone on unmute. Thank you all for joining, and hopefully see you at the next webinar.
Hello, can you hear me? Hello. What happened? Hello.
Hello?
Hi, is that Ross?
Yeah, I've muted the person. I've muted the delegate.
Okay. All right. Thank you.
Thank you.
Hello, can I say something? That's why I unmuted myself.
Okay.
I'm just training a nurse practitioner. She's sitting here with me.
would she be able to get a certificate for attending?
She will have to have registered, because that is the only way we would know who's registered. That is why we wanted people to individually complete the form.
So, right, she's my trainee. She's just joining.
Yeah, I would say, can we have this conversation offline when, you know, when the webinar is finished, because we're currently recording. Once I stop recording, we can have a chat about it, and I can we can have a discussion around. You're speaking to Bola, but after the session, we can have a chat.
Okay, all right.
Thank you.
Thank you.
No problem at all.
Thank you. Thank you, Bini. Thank you, Asha.
Thank you, everyone.
Thank you.
Thanks.
Can I call him? Semua general.